Joining us with some information about the historical context for Massachusetts Department of Mental Health cuts is Donna MAMH. She is the president and CEO of the Massachusetts Association for Mental Health.
Thank you very much, Leah. And hi, everybody. I'm so glad you've joined us today. We're really pleased to be here and be talking to you about this very important issue, which is the resources that are needed to take good care of the people who depend on the Department of Mental Health and other related services in the Commonwealth for their well-being. I wanted to provide a little bit of background today because we're talking about budget cuts. But when you look at the department's budget as proposed by the governor's office for FY26, compared to what the department was appropriated in FY25, it would appear that there is an increase. So you might wonder, why are we here today talking about cuts? Having spent 10 years working at the Department of Mental Health and done as many budgets, and then another 8 years in the Department of Mental Health in Rhode Island, also doing budgets, it is a very common thing for state agencies, particularly those that run state-funded services or purchase services on behalf of the clients who are their constituents, that there are things that are effectively required in any year's budget. And there's really no arguing about it or suggesting maybe you're going to cut this or do that. And those mainly have to do with the costs of the human beings who work in the system, the costs of their labor to deliver care, whether that is because they're delivering that care in the hospitals or certain community programs as state employees, or they're delivering care under a contract in home and community-based services. In Massachusetts, we have Chapter 257, for example, that requires periodic rate adjustments for contracted services in the Commonwealth to ensure that there can be salary increases for the people who work in the field. Similarly, state employees are represented by different collective bargaining groups, different unions, and they negotiate various increases, again, periodically. And it is a requirement of the Department of Mental Health to honor those agreements and honor those negotiated increases. So what happens is you have negotiated increases. And by the way, we know these are very important because we're having a workforce crisis. And in part, that's due to the fact that people have been underpaid. So we need to address this. And no one's arguing that that's not critical to address. But what happens is when an agency has to build in those mandated increases, it drives up the cost of providing the same thing you've been offering before. You're not able to buy more services with that or hire more people with that. So when the department finished paying for all of those things, there was a gap in their budget. And even though it looks like there was an increase in the department, that increase was not sufficient to cover all of the costs of the negotiated Chapter 257 and collective bargaining increases. Thus, the department had to cut services to cover those costs. I'll stop there. I want to just say one other thing, and that is that we had a major cut to the Department of Mental Health's budget back in 2008. The cut this year is $83.7 million. Back then it was, 82.7, just about 83 million. Back then it was about 82 million. It took us most of the 8 years of the previous administration to restore that funding cut. At the same time, we were able, of course, with your advocacy and help and the hard work that everybody does, to see other increases to improve people's access to care, both children and adults' access to care. So it's important to recognize that it is not a simple matter when you get a cut of this level to get it restored quickly. And so this is why we are taking the effort we are to try to ensure that resources are restored to the Department of Mental Health's budget and they don't have to live with the cut and the implications of that cut, which my very capable colleagues are going to shortly tell you about. Thank you.
Thank you, Donna. Here to explain why the proposed cuts to DMH children's programs are of critical concern is Kelly English, Chief Innovation Officer at the Massachusetts Society for the Prevention of Cruelty to Children. She previously served as the Deputy Commissioner for Child, Youth, and Family Services at the Massachusetts Department of Mental Health.
Good afternoon, everyone. Thank you so much for having me here and for your concern about the impact of these proposed cuts on the Department of Mental Health. So just by way of background, the DMH, Child, Youth, and Family Services, serves about 3,000 children with some of the most serious behavioral health needs in our state. And the services that DMH Children's Services provide really serve as kind of a backstop to the insurance-funded system in our state. And as the payer of last resort, and in some cases, DMH serves as the only contractor in the state for certain intensive residential treatment services. So we're pretty concerned about these cuts really eroding the safety net for kids in our state with behavioral health challenges. And would really impact the ability of children to access the critical services that DMH provides. I think we're even more concerned at this point in time, given the looming threat of Medicaid cuts that could be on the horizon. And our concern is we really cannot afford to harm the already weakened public mental health system's ability to respond to the needs of kids with serious mental illness who desperately need the services that DMH provides. What you may hear, and we understand that some of the rationale behind these cuts, in addition to those that Donna shared, are also that on the children's services side, that some of these services are being underutilized, and so therefore that's why they're being focused on for cuts. And as Leah mentioned, I'm familiar with these services as I previously served as a Deputy Commissioner for Child, Youth, and Family Services at the department. And so what I know is that the underutilization of services does not come from a lack of need. We know that every day there are youth and families across the Commonwealth who are in desperate need of these services but are struggling to access it. But really that underutilization is more a symptom of longstanding structural challenges that exist in our children's system of care in our state. I strongly believe that all of us together, and those of you I know who have showed up today, are committed, passionate advocates for mental health services. And so I think all of us together are smart and committed enough to work together to prevent further funding erosion while working together simultaneously to correct problematic structural issues that exist. So I think we can all work together to roll up our sleeves and work with youth, families, providers, funders, and policymakers on working to remediate some of the problematic issues in the system while not harming the kids who desperately need these services today. So I am going to turn it over to my colleague, Courtney Cello, who leads our work of the Children's Mental Health Campaign, to go into a little bit more detail and specifics on the cuts that are being proposed. Courtney.
Thanks, Kelly. Bear with me just a second while I get my slides up for you all. Thank you to the MAMH team for making today possible. Thank you to all of you for being here. I'm going to jump right into it because I have a lot of information to throw at you in a short period of time. The bottom line message from the Children's Mental Health Campaign regarding these cuts is that the legislature needs to hold kids harmless in balancing the state budget. As you heard Kelly say a moment ago, DMH serves about 3,000 kids, and these are 3,000 kids with really complex needs. We cannot balance the budget on them. I will preface kind of my overview of the cuts by just giving a little caveat that we don't have special inside information about the numbers. We have sort of figured out the cut breakdown to the best of our ability based on all of the resources available from the administration, which we appreciate. So these figures might vary slightly from what anyone might be talking about, but I think give a very accurate picture of what the scope of the cuts will look like. So we can use that as sort of a jumping off point to talk about our concerns. And just to reiterate one more piece that Kelly highlighted, we really do, I think, join most of you in looking kind of warily toward what is coming down the pipeline from Washington. We are really concerned about the looming Medicaid cuts that we know are coming. Now really is a time when we need to be shoring up these systems so they can weather the storm, not cutting them preemptively. So with that, I'll get into what these cuts look like. So there are kind of three key pieces here. The first is about a $15.3 million cut to intensive psychiatric residential treatment programs. Now, it is ideal, right? And we all know for kids to be at home, but sometimes residential is the best, safest option for them to stabilize. And we want to make sure that residential is there when kids and families need it. We have been talking with the legislature about these proposed cuts. And of course, right, that bottom line message is please don't cut. If there do need to be cuts, this is a place where we are particularly calling out that not all cuts would be created equal. So there are two programs I want to highlight quickly that really underscore that, because if we lose certain capacities in their system, it's going to be really hard, as you heard from Donna, to get those back. And that is especially true when a program treats a specialized or marginalized population that's relatively small. So first, we have the Clinically Intensive Residential Treatment, or CIRT program, out in Western Mass. Cutchins runs this unit in Belchertown. It is the only unit in the entire state with the capacity to serve 6 to 12-year-old or latency age youth. Special training for these folks, right? We don't want to lose the space. We also don't want to lose our workforce that have developed a specialization in working with young children. What is clinically appropriate for a 6-year-old is very different than what's appropriate for a 16-year-old. We also can't just simply combine units. So if we lose this setting, we can't just send 6-year-olds to units that have 13 to 18-year-olds. Wouldn't be appropriate. Similar story, little different population with the intensive residential treatment programs cut. So if this 50% cut to residential goes through, we would likely lose NFI's program out in Westboro. This is the most centrally located unit in the state, which is really important, right? We know that families being involved in treatment and having visitation is a really important key indicator for outcomes as a kid returns home. And we want to keep that centralized capacity. This is also the only unit in the entire state that has the capacity to provide care for trans and gender diverse youth. And again, right, the team out here in Westboro has developed a specialization in providing sensitive and appropriate care for these kids. We know, right, there's an article in JAMA Pediatrics just a few years ago about how LGBTQ youth are very much impacted by national news around policies that affect LGBTQ people. That at the time was in response to positive news around the fall of DOMA, but we also know that the inverse is true. And so as we see continued attacks from DC, especially on trans youth, we know that the need for these programs is not going to go away. So again, we want to make sure that we maintain this capacity. So we've been asking the legislature that if there do need to be cuts in this space, that there be some protective language to make sure we're protecting this capacity to support specialized and marginalized populations. The second piece of the cut is about $6.7 million in total, made up kind of two pieces of our home and community-based supports. The first $5.2 million is coming out of flex services. You have the official definition of flex here, but what or made Flex real to me was the explanation that these are those services that allow a kid to feel like a kid and also provide some respite or other support to their family. So camperships is a great example. The kid gets to go be part of a peer group and participate in a therapeutic program, and their parents get some respite time. Everybody wins. We understand that most of the cut here is targeted at a newer support covered by Flex, and that is emergency department diversion. The ED diversion contracts were expanded pretty rapidly through the course of the early pandemic in response to the surge in emergency department boarding. These teams have done a remarkable job across the state of transitioning kids out of the emergency department and either getting them into a community-based setting or back home. In particular, they have done a really good job of interrupting the cycle, right? We hear all the time about kids who rapidly are in crisis, go to the ED, go to a community bed, returning home is a crisis unto itself, and repeat. By providing wraparound support in the home to the kid, to the parents, making sure if there are siblings with unmet needs, those are being addressed. They've really been successful in helping to interrupt that cycle and keep kids home. We know that ED boarding numbers are down, which is fantastic. Length of stay is still up. And so you want to celebrate the fact that this is working, but also highlight that while boarding numbers have fallen to pre-pandemic levels, we all get in the way back machine now because it feels like a long time ago. Before the pandemic, we were all talking about the pediatric behavioral health boarding crisis. So I do just want to be clear that while it is cause to celebrate, the need is still there. We need to continue to have this capacity to move kids safely from the ED back home and prevent that from becoming a crisis, that we can keep seeing those numbers driven down. Because if we make cuts here, we will certainly see those numbers go back up. And then just quickly, PACT-Y, or the Program for Assertive Community Treatment for Youth, based on the adult PACT model, was implemented just a few years ago here in Massachusetts for youth. And kind of similar to that wraparound support that the ED diversion teams provide, this is a mobile and intensive team-based approach that brings care to kids in their home. And this is really for kids who have not thrived in our traditional community-based treatment system, right? Their needs are too great and too persistent and not met in the community setting. And so providing that home-based support has been really critical. This has been especially useful out in Western Massachusetts, where we have rural communities where families have a really challenging time getting prescriber access, because trying to manage the needs of a family on top of a couple-hour round-trip drive to see a prescriber is a challenge. And so for our rural communities in particular, want to make sure that we're maintaining this capacity within the system. And the final piece of the cut, which I can be brief on this one, because I think this is probably what folks have heard the most about, because our friends at the unions are doing a great job of sounding the alarm bell on this one, is the $1.8 million in cuts to case management services. I just want to spend a minute here talking about the kid-specific piece of this, because most of the messaging has been around the adult space. And that makes sense because the kid piece is much smaller. DMH currently only has 38 youth case managers for the entire state, and they have a big job cut out for them. Kids have a lot of collateral contacts that adults simply don't. And they're talking to the parents, they're talking to the school, to other state agencies like DCF that might be involved in the kids' care, pediatrician, therapists, the list goes on. Every one of these 38 youth case managers has a full caseload and a very busy job. There is not capacity, if these cuts go through, for any of them to absorb the kids who would be losing case management services. They currently serve a little over 400 kids, so 200 children would be losing access to this support. And we understand that year after year, families say that this is the support that really works, that really helps them to navigate these complex systems. Kelly was talking before about the complex and layered system that families have to navigate. Having case management is really critical for these families. And I also just want to flag that both targeted case management and residential, we do get federal financial participation at 50%. Obviously, the future of Medicaid is unclear at the moment, but for as long as we're getting that federal financial participation, also want to make sure that we are continuing to draw that down. And just another reason why cuts to these services pose a greater challenge than they even look like on the face. I do want to very quickly share one piece of good news in the budget. We have seen a lot of success with the School-Based Behavioral Health Technical Assistance Center providing direct support to our school districts. This is another piece of the puzzle, right? The home and community-based services are really critical, but having support in schools is really necessary for kids, both in terms of that universal promotion and prevention benefit, and also making sure that we are able to help to prevent out-of-district placements as much as possible where appropriate. So looking at a level funding ask for the School-Based Behavioral Health Technical Assistance Center, but shifting that out of the DMH Child and Adolescent line and over to the Fair Share Tax resources, where, it's the one part of the budget where it's all robust, good news. And this would allow that work to be aligned with work that is underway that we're celebrating to develop a statewide birth through higher education school-based behavioral health plan. So I will leave it there. Thank you very much.
Thank you so much, Courtney. My name is Jess LaRochelle, and I'm the Director for Public Policy and Government Relations at the Mass Association for Mental Health. MAMH is also a proud member of the Children's Mental Health Campaign, and we are thrilled we're going to be coming up on the 20th anniversary of the campaign next year. So Courtney very eloquently covered the cuts in the governor's proposed FY26 budget to children, youth, and families. My colleague, Kate Alicante, and I are going to cover the proposed cuts on the adult side. DMH serves approximately 25,000 adult clients per year. And the way that you become an adult client is you have to apply. And DMH looks at the severity of your condition. They looked at the length of time that you've had your condition, and they also look at your functionality. So in the whole realm of all of us adults in Massachusetts with behavioral health conditions, DMH clients represent adults with behavioral health conditions with some of the highest needs and their families. Like the kids cuts that Courtney talked about, the cuts on the adult side, they're not to administration, they're not to overhead or operations. These are direct cuts, proposed cuts to DMH core and contracted services. They're proposed cuts to adult respite expansion, adult community clinical services expansion, case management, just like the youth side that Courtney talked about, the jail diversion program, and Pocasset Mental Health Center. On the adult side, the proposed cuts total $61.5 million. This next slide illustrates, to put the cuts into some context, it illustrates some possible journeys through the adult DMH mental health system. There are many, many journeys through the adult system. These are just a few possible examples. So the left part of this slide, the darkest red, is the most acute and institutional-based services. The goal is to move individuals and families from the left side to the right side of this slide. You can see the darker red to the lighter red side of this slide. The lighter red is living in community with supportive service, achieving as high a level of independence as possible, maintaining and continuing to live in recovery. So if we start at the left side for this example is emergency department boarding, which, as Courtney talked about, is still a problem in the Commonwealth. In fact, as of last Monday, there were 249 adults boarding in Massachusetts emergency departments and medical surgical units. As we move from left to right, the next stop is respite. These are short-term transitional services for people who are moving from one level of care to another. And then as people discharge from respite, there are many, many different options. But just two examples are, in the upper row, is somebody could move into a group living environment with supportive services in community. And those supportive services might take the form of the Adult Community Clinical Services Program, ACCS. Somebody else coming out of respite, they might have the option to go home to their parents or their caregivers' home. So in the bottom row, they might go home, but they also need supportive services, and they might get support through DMH case management. The goal, again, to move from left to right on the slide towards community-based services. And the point I want to make with this slide is that there are cuts at multiple parts of the continuum or system. You can see them for respite, for ACCS, Adult Community Clinical Services, and for case management. These cuts don't only affect the people and families that need these levels of care right now, but a cut at any one part of this continuum throws off or messes up the flow in the entire continuum. So for instance, the cut in the second part, DMH site-based respite, is going to back up everything before it. So cutting respite is going to back up emergency department boarding, putting further strains on hospital emergency departments and acute psychiatric units. So the cuts not only affect people who need the services right now, but by disrupting the flow, they affect people who will need services in the future. Next slide, please. Okay, the first cut, a $9 million proposed cut in the governor's budget to adult respite expansion. What is respite? Respite are generally, as I said, they're short-term services. They're bridge or transitional services. They can be mobile or they can be site-based. So an example of a mobile respite service is a mobile team that literally goes into the emergency department while somebody is boarding to do an assessment and to figure out if that person can live in community and then get them connected to community-based care. So the mobile respite team would move them out of the emergency department to a site-based respite where they would be there for approximately 2 to 4 months to receive bridge services. They'd be getting intervention and support to remain clinically stable. They would be getting care coordination. They would be getting skill building, and they would have that critical and flexible time to be able to figure out what services are next for them to live successfully in community and maintain recovery. What's important to know here is that the current DMH adult respite program, it's at capacity. So a cut to the expansion means that DMH, there will be no more slots because we can't meet current demand. So with the cut, we won't be able to meet future demand as well. Next slide, please. The next proposed cut in the governor's budget on the adult side is to the Adult Community Clinical Service Program, ACCS. ACCS is really the cornerstone of DMH community-based services. So of all adults that receive DMH community-based services, about 3/4 of them get ACCS. ACCS is incredibly comprehensive. It includes clinical supports, it includes peer and family supports, and it also takes a holistic view of health and well-being. It also includes vocational supports and housing supports. Again, ACCS, just like respite, is operating at capacity. And with this cut, DMH will not be able to expand ACCS capacity by an additional 200 beds. So, and this also, not only does this not make sense from a human perspective, these cuts, it doesn't make sense from a fiscal perspective. community-based placements are far more cheaper than acute and institutional placements. So if we erode the community-based system, not only is it going to hurt people and families, but it's going to be more expensive to the Commonwealth. Next slide, please. And the final cut to DMH adult services that I'll talk about is case management, which Courtney already touched on for children, youth, and families. And what I'll add to this is that, and this applies both on the youth side and the adult side, but the way the layoffs of caseworkers would work is that people who are hired most recently have the least protections, and those workers would be the first to go. DMH in recent years has been really conscientious about trying to hire workforce that is linguistically, racially, and ethnically diverse. So with these case management cuts, it's going to significantly affect the cultural responsiveness of our case management workforce, which in turn is going to hurt the therapeutic relationship between individuals and their case managers. So in addition to just cutting case management, we also have major concerns about this cut from a health equity and access perspective. And with that, I'm going to turn the presentation over to my colleague, Kate Alicante. She is our Senior Policy Research Associate. And Kate is going to talk to you about the cuts to the DMH jail diversion program and also some advocacy that needs to be done around supportive housing programs. Thank you.
Thank you, Jess. The next program that I'm going to discuss that is subject to cuts in the governor's budget is the DMH Jail and Arrest Diversion Grant Program. We know that there are too many individuals experiencing a behavioral health crisis who are arrested or incarcerated rather than connected to what they really need, which is urgent therapeutic services and supports. One stat estimates that 20% of police calls for service are in response to someone in a mental health or substance use crisis. I will say that we gave this presentation to some people on the DMH area boards, and that little citation that, some areas have higher estimates. I have heard from people in other local police departments echoing that this 20% is definitely on the lower end. So the DMH Jail Arrest and Diversion Grant Program started in 2007. The program actually developed and is modeled after a program that started here in Massachusetts in 2003. Massachusetts had the first co-response model in the country, which is embedding a clinician in the police department to ride along with the police and co-respond to individuals in a behavioral health crisis. And that started in Framingham. So this program that we have in Massachusetts that started here, that's across the state, is really a model for the country. So it would be incredibly disappointing if we cut something that we have been leading on. As of last year in fiscal year 25, DMH has distributed funds to 117 grantees. So there are many cities and towns and individuals across our Commonwealth who are benefiting from this program. In addition, DMH also funds 9 regional crisis intervention and co-response training and technical assistance centers, otherwise known as TTACs, to kind of strengthen the pre-arrest diversion practices statewide, as well as providing training, skill development, and strategies for crisis call resolution. In fiscal year 25, this program diverted to over 2,300 individuals from arrest and over 3,600 individuals from the ED, again, saving nearly $28 million. So I think that stat really highlights the human impact of over 2,300 people not being arrested and over 3,600 people not going to EDs. But, the point we've really been trying to, again, hammer across to the governor and the legislature is this program saves money. And actually every dollar invested in this program saves the Commonwealth $4. And it's not only helping save money for DMH, it's also saving money across many stakeholders, including DOC, the courts. It's saving monies for our hospitals and the emergency departments, and it's also saving money for Mass Health. So currently the governor's budget proposal has $3.8 million for the program, and we're seeking an additional $14.2 million to cover this, to make up the cut and cover the full annualized value of the requests received both from the police departments and the T-Tax last year. So we're asking for a total of $18 million for this program. The next pieces that I will be talking about aren't cuts, but it's a focus on some supportive housing. You'll see this graphic. It looks it's just a cutout version of the graphic Jess showed, again, showing the respite she's talked about, the ACCS she's talked about. And I really just want to shift our focus again to the far right for the DMH rental subsidy program, which is, again, us trying to get people into the community, which is less expensive. And we're focusing on housing because, again, we know it's one of those fundamental social determinants of health, and specifically supportive housing. We know is very important in order for people with behavioral health conditions to live in stable environments. Actually, recently, the Department of Public Health did a community health equity survey on mental health, and they found that adults who had a steady place to live, but were still worried about losing their housing, had similar rates of psychological distress, suicidal ideation, and social isolation compared to adults who reported having no steady place to live. So really having that stability and not fearing that you're losing housing is incredibly critical. And like Jess pointed out, the respite ACCS are at capacity. And as everyone's pointed out, even though ED boarding is going down, like Courtney said, for the kids, it's also going down for the adults. We still have people ED boarding. And so we want to invest still in the DMH rental subsidy program, again, to just help people flow through the system. So a little bit more about the DMH RSP program. In addition to helping those flowing through that system in the previous chart, it's also helping individuals who are experiencing homelessness. DMH also has a project that helps people transitioning from homelessness, and they outreach to individuals who are homeless. And last year alone, they reached out to 2,100 individuals. And also last year, we know that there were nearly 3,000 homeless individuals with severe and disabling mental health conditions. So we know there are people in our DMH system. We know there are people in the shelters. We know there are people in the streets who could benefit from the program, which ultimately how it works is a DMH client would pay 30% of their adjusted income to their rent. But in addition, again, they would get that support. They would get that service through their community providers. So in summary, we're asking for the DMH rental subsidy program for a little over 41 million, which is a 5 million increase from last year, which would support another 300 vouchers for DMH clients. So in total, that would be a little over 2,800 vouchers. And the legislature has been good and over our past budgets of increasing our investment in the RSP. And so we're really just hoping to continue that trend. One last final housing program before we'll open it up to questions is the DMH Safe Havens program. Safe Havens uses what we call a housing first model, which means providing the housing without requiring treatment or sobriety as a prerequisite. Again, these programs are supportive housing, they're supervised housing, and these are for our incredibly difficult, hard to reach, hard to engage individuals. These individuals are among the highest users of our emergency departments, our hospital beds, our emergency medical services, and they have high rates of trauma and criminal legal system involvement. And so you know, these individuals have, you know, some mistrust of the system, understandably, and what a DMH Safe Haven does is kind of help build that relationship to start. And so, again, some good news to you know, I guess end this before we open up for questions is the governor's budget does include $29.7 million for this program, which is an over $3 million increase for the program. And what that increase would cover is annualizing 3 new safe havens we added on last year, 26 beds. So in total, we would have 18 safe havens and 161 beds. So I'll conclude there, and I will stop sharing my screen and open it up to questions.
Great. Thanks so much, Kate. So if folks, we see that there's been some great questions coming through and comments in the Q&A. So I know there's been a few comments that have come through, you know, one noting that, you know, cuts anywhere to the Department of Mental Health system would really cause downward pressure in the rest of the system. So it's not only the folks who may be receiving DMH services today, but certainly when there isn't as much access to a deep end level of care like intensive residential treatment, for example, you know, that kind of creates downward pressure on the rest of the system. So kids who may be waiting in an emergency department for a bed, who may be stuck on an inpatient unit, maybe having longer lengths of stay because they can't access those services. So I think it's important to kind of contextualize that as well, that these cuts really do impact everyone, no matter kind of where they are in the system. I know there was a question that came through about kind of wondering about the governor's involvement and her perspective on these cuts. So Courtney, I think you were going to respond to that one.
Yeah, so I popped a quick answer in the chat, but just wanted to kind of elaborate a little bit. So yes, this is the governor's budget proposal. It has come sort of, right, like, she did not sit down and craft this directly, but did you know, sign off on putting this proposal forward in order to balance the budget, which I will just say I never want to be in the position of balancing the state budget, so not an enviable job. You know, this is a symbolic first step. There is still a lot of time now to do some work as advocates, as providers, as family members, and individuals impacted by these cuts, to talk to the legislature, the House and the Senate, as they go through their process, because this is by no means the final version of the FY26 budget. The governor has also been open to advocacy about the impact of the cuts that are laid out in House 1. And so, you know, we have been very vocal in explaining our concerns about these cuts to the administration. We would welcome all of you to voice your concerns as well. But lots of opportunity and lots of road between here and the end of May to work with the legislature to help to influence what that final budget looks like.
Great, thanks so much, Courtney. There was another question just wondering about were the cuts that Donna, that you mentioned earlier on in the presentation, and how there was some wondering about that there may have been cuts even before that to the Department of Mental Health, and just wondering how those were compared to, you know, that they may have been affecting day programs or other kinds of programs, and wondering how the cuts today may compare to what was happening, you know, 20 or 30 years ago in today's dollars. I don't know if that's something you can share a little bit about.
I don't have that calculus to answer that question accurately, but I will say that the department has actually had what I would call a structural deficit for a few years now. For example, during COVID, DMH was in the same, in terms of running its hospitals, along with DPH, was in the same boat as hospitals all over the country, whether they were state hospitals or general hospitals or private hospitals. And that was having challenges staying fully staffed. And you have to have minimum levels of certain licensed personnel to meet the requirements, the conditions of participation for Medicaid and Medicare, for example, or other requirements for licensure and certification and accreditation. And in order to maintain those minimal levels, they had to hire travel nurses or temporary personnel on contracts because they could not recruit and retain enough employees in regular positions. And so the cost of doing that is sometimes double or more what a salary and benefits are. And in order to stay on top of what was required to safely take care of patients and clients and some of the community programs, they did what they had to do, but it created deficits in their budget. So they've, you know, I do not envy the job they have had trying to juggle all of that. And this is, you know, one of the challenges for all the parts of our healthcare system that inevitably rely on a workforce to deliver care.
Great. Thanks so much, Donna.
Yeah.
A couple of questions just generally about the state budget and also wondering if anybody here, I know I've been in part of some of meetings with folks in the legislature about kind of their position and where they may be on some of these proposed cuts. You know, if Jess or Courtney or want to speak to kind of what we're hearing generally.
Sure, I'll start, and then maybe Courtney and Kate, you can also, because we have been in some meetings together, but then also in different meetings. I think a lot of work needs to be done to educate everybody, both the public and the legislature, about all of these cuts. There are some really important ones that have gotten a lot of attention in the press, as they should. And there are also, I think, a lot that we talked about today that aren't and are just as important, and people don't know about them yet. So we're kind of doing a two-front, kind of educating and raising awareness as much as possible. Fortunately, a lot of the folks that we talked to are pretty dismayed by these cuts, especially based on the calls that they're getting from constituents in their districts and the ongoing mental health needs. At the same time, there are fiscal pressures. And I think our message again and again, Courtney, you said it, like, hold kids harmless, like cutting behavioral health. This is not who we are as a Commonwealth or an expression of our values. Courtney, Kate, do you have anything to add?
I think I'll add just, you know, we're hearing similar things across a lot of these meetings, right? Folks are concerned about the cuts more than, there have been smaller cuts to other programs over the years, and we often show up to meetings with legislators and they haven't heard yet from their constituents about them. Everyone is very aware of these cuts. If you are able to reach out to your rep and senator, though, do help add to that pile of voices that they're hearing, and help provide a little context if you can, in whatever way you're impacted by the cuts. It's helpful for them to hear, you know, not just the numbers and not just, you know, us contextualizing it, but really to have a face and a name from the district to put to that impact. You know, it makes it real for them, and it also gives them something to hold on to take to their meeting with Ways and Means.
Terrific. Thanks so much, Courtney. Yeah, I'm seeing, and I know you want to transition us to do kind of a call to action, which I already heard you start to signal, you know, and some of the things I'm seeing in the chat about the impacts on folks, you know, people who are ready for discharge from hospitals, who are experiencing long waits today and worries about that getting even longer. So I think those are the kinds of examples of things that it would be really helpful for folks in the legislature to hear as they prepare the budget. So Courtney, I wonder if you could share a little bit about kind the call to action and where do we go from here?
Sure thing. So, in addition to taking advantage of opportunities to weigh in with your legislators, and there's a QR code here so that you can do that right now. We will be sharing another action alert next week, specific to the kid cuts that will also include an invitation so that you can directly invite legislators to join us in our day of action. And we hope that you will come too. So on April 17th at 2 p.m., this is truly breaking news. First time we are sharing this out. State House Room 437, please join us. We will have a brief speaking program, and then we are actually going to support folks in getting out around the building to meet with their legislators, to talk to House and Senate leadership. Notably, right, so the folks who are really invested in the state budget process know this is likely the day after the House Ways and Means budget proposal will drop, which means it is about a week or so before, week and a half before the House will take up debating the budget. This is going to be a really critical intervention point for us. So we hope to see lots of folks there being visible, wearing either your organizational t-shirts or green for mental health awareness. We are also working on some plans to convene on the front steps out front of the State House at 1 p.m. Beforehand for a little press and photo op. So stay tuned. We'll be sharing more details about this event as we move through this next week or so. But you are all the first to make the invite list. So we hope to see you all there. And finally, please do stay informed throughout this process. We've got links to the campaign and MAMH email lists in the chat. We will be sending out a lot of information, keeping you up to date every step of the way on these cuts. MAMH are comprehensively the adult and kids systems here, and on the kids end, keeping you up to date on what's happening with the proposed cuts to kids. Yeah, with that, your voices do matter in all of this. It makes a difference. Thank you for being here. Please keep in touch and please take advantage of these opportunities to weigh in with the legislature because it's far from over. It's a long process to build a budget.
Thank you all.